I have a distinguished panel. I'm going to briefly introduce them, and then we're going to invite each of them to speak for around 10 to maybe 15 minutes, and then we'll have a brief chance for them to react to each other, and then I am going to persist in trying to get you to ask questions and challenge us, or at least to make the talk more interesting. So on my left is Audrey Laporte, who is an associate professor of health economics at the Institute for Health Policy and Management at the University of Toronto in Canada. And Mark Stabile is next to her, and he is a professor of economics at INSEAD here in France. And then next to him is Agnès Couffinhal, who is a senior economist and also longtime friend at OECD. And I just learned over lunch that she was also a student of Lise Rocher, so that is special. And then the fourth speaker will be Herrera, and he has recently joined the staff at Hospinnomics, and I believe he is also a PhD student of Lise Rocher. So. Excuse me, I'm sorry, James, my mistake, excuse me. Anyway, he's just joined here from Harvard University School of Public Health. So we have a really interesting panel, and our topic is understanding public decision-making in health.
So the other day, very recently, I was looking at The Economist, and there was an article in there about the tribulations of the British NHS. And it concluded by recommending that what the NHS needed was to adopt American-style accountable care organizations. And then a couple days later, I was perusing the New York Times, only to find an article saying that Dartmouth College was the intellectual home of accountable care organizations, was actually going to shut down its own accountable care organization. And so two things kind of came to mind. One was that there's probably not a single magic bullet that's going to solve all our problems. And the second is that it's really difficult to design a high-performing healthcare system. So picking up on the theme of this conference, we have a really important issue that's raised, and that is that decision makers often are faced with having to decide whose preferences should prevail. Those of the individual patient or those of the general public. And this raises the obvious question as to why those might be inconsistent with one another, or why they might be in conflict. Because we often tend to assume that the public planner is maximizing some form of social welfare, which is some kind of aggregation of the welfare of individuals. It's often said that economics does not apply in the context of health and healthcare, but I'm going to suggest that the tools of economics give us some insight into this tension. And they allow us to see that it's not simply a difference in preferences, but really a difference in the constraints and the opportunity costs faced by the individual versus the public planner, even when in effect the same decision is being made. So a good example of that would be antibiotic resistance, which is a growing public health problem. And economics looks at this as an example of a failure of the individual to take account of the negative externalities that result from their own behavior. And we can see that at the individual patient level, the benefits and the costs are pretty clear, pretty straightforward. The individual wants to take some pills to get rid of a sickness, even if eventually the body might overcome that sickness on its own. The cost is the cost of the pills. From a social welfare perspective, however, we know that casual use of prescribing in the antibiotics leads to resistance. And even when we have individuals that are aware of this as a problem, they tend to view their own contribution to it as being very small compared to the potential benefit. And economists could analyze this problem with essentially the same tools they would use to analyze the common resource problem, like an open access fishery with the same result in that you get overfishing, right? The fisherman of today benefits at the expense of the fisherman of tomorrow. And what this example illustrates is the reason that public planners have to take a longer run view than do individuals, which then leads to the question of whether public planners are always able to take a longer run view. And here I'll refer to another example. In Canada and the UK and other countries, we have something called bed blockers, which is a rather nasty way of referring to elderly people that are in hospitals but don't need hospital care because there is insufficient institutional or community-based care. And this is a consequence of the aging population. In North America, we've had the baby boom and they're moving through the life course. And so we saw this coming. This is not a surprise. We've had the example of Japan to look at, and yet we're scrambling. We're scrambling in many cases to accommodate this. So the question is, why didn't they take a long-run view? Some might say that it's cynically that it's because of political imperatives. And so we have to think about how to protect healthcare systems from politics. We also have the issue of differences in opportunity costs at the level of the planner and the level of the individual. A planner faced with a fixed budget constraint has to trade off health conditions, one health outcome for one group against that of another. So under a fixed budget, I want to improve the health of one group. That's going to come at the expense of another. That's my trade-off. At the individual level, I may want to improve my health. The trade-off could be I don't buy that large screen TV. It could be that I don't eat McDonald's hamburgers. So the individual has a broader set of trade-offs. And the implication of that is that even if the individual and the planner agree on what the benefit is of a particular healthcare treatment for that individual, the planner may have a higher opportunity cost associated with that. And that may lead to allocation decisions that the individual resents, leads to discontent, leads to a sense of unmet need. It's also important to recognize the informational requirements. And it's not just the difficulty in knowing how many people are going to have a particular disease and what we're going to need to treat them. It's also a lack of information vis-a-vis how individuals respond to incentives and information about basic economic concepts like the elasticity of supply and demand. So in Ontario, for example, the public payer decided that they wanted to move primary care physicians from a fee-for-service model towards an alternative payment model. And to kind of sweeten it, to encourage people to move, they increased the salary, and they informed doctors about how much their salary would increase if they switched. So there was a massive shift of physicians from fee-for-service over to these models, to the point where the government then had to impose limits and stop the switching, which then really annoyed the doctors who wanted to switch but hadn't switched quickly enough. And so now this is a point of contention in the latest negotiations. On the demand side, the government of Ontario recently decided to fund in vitro fertilization. And this has led to years-long waiting lists. And in the US, we have the example of a shortage of some generic drugs. So these are examples about how misjudging how individuals will respond, what their preferences are, can lead to budgetary pressures, unanticipated ones. And this often leads to the imposition of quantity constraints, usually in a suboptimal fashion. Governments get into the business of providing health care to ensure that no one loses out on getting necessary care because of financial reasons. But it's difficult to devise a pure insurance system that is non-inflationary. And as a consequence, governments tend to get involved on the supply side. And this causes the issues we've talked about in terms of opportunity costs to loom larger and larger. People want to get services, and they want other people to pay for those services. And this leads to pressure on public budgets. So is it possible to design a healthcare system that is non-inflationary, that has short-run flexibility in production decisions, and allows the planner to take a long-run view? I think, arguably this brings us into the territory of Coase's theory of the nature of the firm, where the market decides how centralized the production is going to be. And you centralize to the point where the benefits, which are in the form of reduced transactions costs, are greater than the costs. And when that's no longer true, you get these upstarts, firms that start to become competitors. But I don't think any of us would recommend this as a mechanism by which we should decide who gets health care and who does not. And I think most of us agree that the public sector should have the exclusive, if not the most important role in designing a healthcare system, and that the aim should be maximizing social welfare subject to constraints. But having said that, let's bring ourselves back to the theme of the meeting. And there certainly are healthcare systems that outperform others. But it's also true to say that it'd be difficult to identify a system in which there weren't some significant discontents. And I've argued here in brief that these discontents have their root in fundamental differences between how the public sector and the private sector evaluate healthcare needs and healthcare values. And it's important to recognize, too, that these discontents aren't sort of rooted in ignorance and or base political posturing. They are both a bug and a feature. And as health system planners, we have to accept and operate within that constraint. Thank you very much.
Thanks. Well, thank you very much. Thank you for inviting me. My remarks are going to pick up remarkably consistently from where Audrey left off, and that's good news for me. I was asked to talk a little bit about the trade-offs associated with financing public healthcare systems, and so I'm going to speak a little bit more at the macro level about the trade-offs in financing. And I think before you can think hard about financing trade-offs, you need to start with goals. So what is it that we hope a healthcare system is going to achieve? And you can look at any number of studies for a set of goals that are useful. I'll give you some brief ones from the WHO, the World Health Organization, which has very broad goals of achieving good health, responding to the expectations of the population, and thinking about the fairness of financial contribution. And within all of those three, they focus in on not only the mean performance of the system, but the distribution within the system as well. Right? And if we take those goals, or some version of those goals, you can take others, as a background, then we will also note that the goals have remained fairly constant over time. Right? You can go back 20, 30, 40 years, and the goals of our healthcare systems haven't changed very much. How do we measure, however, how the system is doing to meet those goals? And if you look at studies that have tried to do that, you start to see some of the challenges. Right? So we measure mortality or morbidity, we measure access or choice or wait times, we measure distribution or equity within the above, we measure progressivity of the financing structure, and we measure efficiency and how we achieve those goals. And certainly from the public's perspective, or the public system's perspective, but not uniquely, private insurers also are thinking about this, we have to add on to that how we're managing costs. Efficiency and costs are not the same. And we'll hear often the word sustainability of a public system or private system used. I don't like the word sustainability very much overall in healthcare, but from the public's perspective, at least, the public system perspective, I used to work for a finance minister, and the way they think about this is, can we afford this in the public budget? And if you were to take a look at how public systems were doing over time, and you looked before the financial crisis of 2008, you would see that in almost every healthcare system, healthcare costs had been growing faster than GDP. And so each year, for those systems that were majority public systems, we would have to find more public money, or else either raise taxes, borrow more, or take money from another ministry or another department to keep funding healthcare. Post 2008, maybe my colleague from the OECD will talk a bit about this, I don't know. That seems to have frozen a little bit, right? Interestingly, while we don't see healthcare costs growing as quickly as we did pre-financial crisis, we do see that subcomponents, namely private costs, have been growing. And so what we might think has happened is that as public budgets faced austerity constraints, cutbacks for a variety of reasons, more of the burden was put on the private system. Right? And once we think about that as a response, we might think that this has some implications for the topic that we're thinking about here, which is the trade-offs in financing public systems. Okay? I group in work that I've done public coverage into 4 broad models, and there are other categorizations that might work equally well, but I think of one model as broad public coverage with a parallel private system, and the UK system might be an example of that. You might think of a model where you have broad coverage and then co-payments within that broad public coverage. France would be an example of that kind of system. You might have a group system like the US where you're publicly covering some populations and not others. And you might have a sectoral system, that's my 4th, and Canada is my prime example of a sectoral system where we choose to cover some things publicly and leave other things privately. And you can think of many variations or combinations of these 4 groups, and you might think, oh, my country doesn't fit into any one of these groups. That's okay, it can fit into many. But it allowed me to ask the question, do public and private finance represent independent sources of funding for a system, or do they tend to substitute or crowd each other out when you see infusions of one or the other? And does this relationship actually depend on the kind of system you start with? Or does it differ depending on the kind of system you start with? We have a reasonable amount of evidence within systems, within the US in particular, looking at populations like the Medicaid population. There's less evidence across countries, and I'm going to I took a look at within country changes over time using comparative data from the OECD. Lots of issues with trying to do this, but what I have found is that in fact we find a very negative relationship between the level of private financing and the level of public financing over time within a country. I'm not comparing countries with higher private financing with those with lower. I'm comparing changes over time within a country. And importantly, the relationship between these two, calling it an effect is a bit extreme, the relationship between these two actually does depend heavily on the kind of system you have. It's most severe in a sectoral system like Canada's, but it's also quite severe in those co-payment systems like France's, right, where you see it's much easier in a sense to quickly shift the burden from public to private and vice versa, because the mechanisms are so easily built in. Okay? And there's a lot of detail in this kinds of thing, but it suggests that indeed when we think about the trade-offs we're making at the public level, we have to also think quite carefully about the effects these trade-offs are going to have at the private level as well. And there's lots of reasons we might worry about this. Equity is certainly one, and how you feel about equity depends on what country you're from and what system you're in. I'm currently teaching at INSEAD. It's a business school where we get a representation of many, many countries. If you ask them the question, do you care about equity in a healthcare system, you get a very, very different response than I used to get when I asked that same question in Canada. I'll let you figure out how they answer. But we might care as economists, even if we pause on the pure equity side, because of some fiscal feedbacks or externalities that these kinds of changes can cause. What happens when you infuse more public finance or private finance into a system on the other? And I'm most interested in the effect of infusing more private finance on the public system. And here, there actually is a fair amount of evidence that people have done over time that suggests a list of things we might worry about, including physician shifting from public to private systems, less attention paid to public lists, increased demand overall, cream skimming within the system, increased use of public services as complements to private care or private insurance, and somewhat worryingly, we haven't actually found that infusing more private money leads to a reduction in costs in the public system. That one we haven't been able to find. So can we resolve some of these externalities or fiscal feedbacks, depending on how you want to think about it? And yes, I mean, there's lots of scope for regulation or taxation to try and deal with this, but it's tricky. And I don't think any system has it quite right yet. And it inevitably leads, when you think about this, to a discussion, at least for me, a consideration of, therefore, how do we actually think about what we're going to provide publicly if we have to worry a bit about the way the private system is going to feed back into what we provide publicly. And here, I mean, we have seen lots of changes over time in the healthcare space. What hasn't changed very, very quickly is our needs. Our needs do evolve, but they evolve more slowly over time. What's changed more quickly is how we treat those needs, right? The way we access care, the information we have as citizens, the threat of growing inequalities. These things we've seen change a lot more quickly than changes that we've seen in the actual needs that we need to treat. And in my view, those kinds of changes actually call for a more engaged state, not a less engaged state. In times of rapid change, if the state doesn't stay engaged, we get what I have called, and others I'm sure, passive privatization of systems that actually weren't meant to be privatized in some ways, but ended up being that way. And Canada actually is an example of that. We managed to not cover prescription drugs for an awful lot of people, even though it's become an important method of delivery for healthcare. And that's not because we don't think that drugs are important. That's because we set up a system that is too slow to respond to changes in delivery. But that's basically how that's happened. Perhaps I will just wrap up at this point and say that, to my mind, it makes more sense to think about the public domain as defined by best evidence on how to meet population health needs, and the private domain as defined more on what we exclude from our decision making around the public domain. So the private domain becomes the default instead of what's driving. And that's easier to say than it is to implement, but I think that's the direction that I would advocate going. This doesn't mean we're going to get rid of perceived or actual inequalities, but if we do this right, we might hope that the contribution of the private sector to any inequalities in access are not going to actually add to inequalities in health and quality of life, which may be what we're actually worried about. And I'll stop there. Thank you.
Good afternoon, and thank you also for inviting me today. It's really nice because we didn't have a chance to talk before this panel, and so far we seem to be taking completely different tacks on this topic. So I'm delighted to say that I won't be repeating what my colleagues have said so far. I've actually taken a quite different approach to this question, which is really perhaps born from my experience working with governments and also looking at policies. So my angle is much more on the policy level. How do governments or how do policymakers really try to, in practical terms, factor in the preferences of the individuals in their decision-making processes and the various things that they have to do. And I'm going to leave aside the question of competition because this is really one way of saying, well, we're leaving space for individual decisions. So I'm putting this aside, even though it's a question that's still very, very important to decision makers in some reforms, even currently. But I'm going to start with two preliminary remarks. The first one is that I believe there is really a secular trend of making an increasing effort to actually include the public in the decision process when it comes to the health sector. This has really increased in the last 10 to 15 years, and it's become more important in a range of countries. This may have to do with, consumerism and general trends that do not just affect the health system, but also perhaps it might indicate also a shift in the model of medicine, which is becoming less paternalistic. So when you take account, you realize that the individuals have a say into their health, and you might want to involve them more instead of having a direct approach to tell them what they're supposed to do. And of course, and this topic has been raised by different speakers before, is when you start thinking about how, as a policymaker, am I going to involve the patients or the people, the individuals, in the decision-making process, then of course you have to think a little more in depth about, well, who are these individuals? And I would argue that you have the individuals and then the individuals, so the aggregation of the other individuals. And these are two completely different ways of looking at things. So on the one hand, to simplify, you have the patient who cares about outcomes in a very immediate way, outcomes, access, and also the experience of receiving care. And then you have the citizens' preferences, or the individuals, the group of individuals, which is really the policy perspective. Outcomes, they look more at outcomes and the value of these outcomes on a societal level, the cost and the fiscal sustainability, or rather than access per se, more equity. So I try to think of the ways that, again, policymakers use, and I think I could map two broad categories. One is really about trying to involve the individuals more in the decision-making process, and the other set is about factoring in the individual preferences in the tools that guide the decision-making process. So one is direct and one is more indirect. On the direct, I would say the first obvious one is really through the use of citizens' engagement, excuse me. So this is really, in theory, this is the role of the elected representative, right? The elected representative is supposed to represent in the decision-making process the interest of the people who have voted for them. But in reality, there's always paradox, and I could tell you interesting anecdotes about this that I've met. So what I've seen in different systems is either the involvement on ad hoc specific topics. So you call this national conferences, national consultations, citizens jury. Citizens conferences, and these tend to be around topics that have an ethical dimension. So, for instance, end-of-life care, or consensus conference on the use of opioids, or things like that. And then you have also countries which have chosen to really put in the health sector more formalized institutions that try to elicit the preferences of the individuals and or society. And here I'll just take the example of France, because it's more institutionalized, and in France we love our institutions. So you have, for instance, at the national level, something called the National Health Conference, which is supposed to provide opinions, formulate opinions on the laws, etc., on behalf of lay people or citizen and so on. But also at the level of for local planning, in each region you have forums that are specifically organized to try to get the citizens to be involved and have a voice in the process. Now this is really about getting a consultation, so consulting the people specifically in the health sector. The other type of direct involvement that I could think of is really about giving specifically to citizens or patients' representative the right to have a say in the matter, so to vote in a sense, but specifically for the health sector. And here, the example I'm going to take is the example of decisions which are made to decide on the benefits basket in different countries. So what is going to be covered by public funds versus what is not going to be covered. Now, some countries, not all of them, have some form of HTA, and I'm sure many of many of you know much more about this than I do, but essentially you can distinguish two stages. One is the assessment, where you actually collect evidence and gather evidence on the efficacy of the content, etc. And then there is the appraisal stage, where you actually take this information and formulate by some process an opinion about whether or not this particular technology should be included in the benefits basket. And so there are countries for which this appraisal stage is actually based on a vote, and in which the citizens actually have a say. Interestingly, so we're actually, the OECD is going to publish soon a working paper on generally how benefits baskets are defined and decided across OECD countries. And I took a look at this in preparation for this conference. And actually, we could only identify 7 countries in OECD in which citizens actually have a voice in the process. And 2 additional ones when they are consulted, but that's going more to the first modality I was talking about. So it's not as common as you think, actually. And I thought this was interesting. This actually surprised me. Now, I'm going to come to the second type of involvement, which is more about incorporating the reflecting societal preferences in the decision process. And again, I'm going to follow the example of this appraisal stage in an HTA process. Some countries actually, when it comes to this appraisal stage, actually formulate criteria for saying, so we said, earlier, we were saying, equality is equality is equality, but in reality, societies don't believe that. And so what some countries are doing is actually, when there is a group of people who are going to be put together, whether it involves citizens or not, to actually decide on this, they say, well, for us, what the societal values are A, B, and C, and this is how we're going to these are the criteria that we're going to use. And again, in this working paper, you will find, that different countries have used different criteria, but it includes, the burden of disease or the feasibility of implementation. It's quite interesting because countries have different, the potential impact on financial impact, the out-of-pocket payment impact of the decision to introduce or not the technology. So there's a great variety across countries. In terms of trend, there is a trend that we've, for now, it's mostly literature, literature, but it might come at a later stage in the decision-making process. But there is a growing interest in what is called a multi-criteria decision analysis as part of the HTA process, which is basically would consist in formalizing the preferences and incorporating this into the model. So saying, we value equity by this much, and this is how we will factor this in. And so trying to model in a way the preferences to try to come up with an input or an additional input into the decision model. Now, the last thing I wanted to talk about is really reflecting individuals' preferences again in the modeling. And we've talked a lot about quality, so I'm not going to go into this, but I want to talk about a trend which I think I find interesting, is the increasing use in terms of the increasing use of patient-related patient-reported outcome measures, so the so-called PROMs. So what is a PROM? Well, the PROM is part of equality. It's basically asking people, and we were talking earlier about EQ5D. So it's really asking people about their experience in the process of care, and using this also in real life for decision making in the policy arena. So basically what you do is you ask a patient, before surgery how they feel, and after surgery how they feel, and you do that quite systematically, and you use this information. And the reason why it's interesting is it really adds a degree of understanding about of the performance of providers. So I have an example for colorectal cancer in Germany, where the survival rate, the 5-year survival rate across providers is virtually the same. There's hardly any variation. But if you actually look at what really matters to patients, and so really individuals' preferences, incontinence, severe erectile dysfunction, then the variation across provider is quite consistent, and the providers really have different level of performance in terms of what they can achieve for that really matters to the patient. So essentially all I'm trying to say is that this is kind of a new trend in incorporating individuals' preferences in the decision-making process. So you can publish the information and make it public, and this is what the NHS does, for instance, because they collect PROMs on forced surgeries, and they say then it helps patients guide, based on information, things that they really care about. You can also use it for the real-world evaluation of benefits. So there's another example where they collected PROMs after knee surgery and looked at which specific prosthesis had been used. And there were four possible prostheses, and the two most expensive one consistently gave worse outcomes. So they simply decided to delist the two most expensive ones, not because they were more expensive, but because they were not providing as good quality. So this is interesting. You can also think about paying for performance based on PROMs. So it's kind of mandatory, but I have to tell you that the OECD is actually looking to collect more data on PROMs and PRETs to increase. Basically. Improve the way we measure performance across healthcare systems. So this is a project we're going to launch in the near future. So this is also why I wanted to finish with this point. Thank you.
Okay, so thank you for being here. I'm clearly the person with less experience in the panel. So forgive me if I'm not very precise or so. I clearly agree with Mark that needs don't change in the health, when we're speaking about health. And clearly, when we're dealing with programs that are effectively health, you have to take into account that you are both going to have either positive or negative effects in the health. So, for example, so I know that, again, Mark, sorry about that. We love to use the VLIP system. So there you could have either a positive effect on your health because you're using more the bikes, hence you're doing more exercise, and that's going to increase your level of health. But then on the other hand, you're going to have a decrease of your level of health because you might observe an increase of the probability of you having an injury or just either by having a car accident or by having just your muscle that is going to work out too much. So again, for example, if we want to increase the policy, sorry about that. I usually get nervous presenting in front of people, so sorry about that. Okay, so when governments want to propose, for example, a policy which is increasing your level of an advisory that wants to increase your level of food consumption on fish. So that's going to be a nice policy in some sense because that's going to increase the amount of fatty acids that you're going to consume as regard to the alternative. But and that's going to be beneficial for one part of the society, but not for another. And for example, by consuming more fish, you're going to consume more methylmercury. And for persons that are going to be pregnant, methylmercury has been linked with increases in neurocognitive deficits. So clearly, you have a policy here that presents both trade-offs, either positive effects on your health, negative effects on your health, that might be to persons that are not related at all. So the question is, how do we relate with those? How do we deal with those trade-offs? And Jim clearly made a pretty good explanation on that this morning, this afternoon, in which basically we need a convention. And there are two conventions that we could use. Either one convention which is putting a monetary value on a health benefit that is actually a pretty easy thing to compare if you want to evaluate the costs to a particular policy. And, sorry. I really get nervous. And I'm also filmed. So that's, okay. But, and that's going to lead to a benefit cost analysis, which is usually, and as Jim said this morning, cost benefit analysis is actually a good thing to do if you want to satisfy this Calder-Hicks criteria that you were talking about. So imagine you have this policy that increases the health benefits to one side and to one side of the population, but then you have another side of the population that is affected. Then you could think about this this policy that, or a costless redistribution policy that is going to transfer some money, let's say, into those who benefit from the policy to those that don't benefit from the policy, which would be a good thing to do. But the problem is, and what has the cost-benefit analysis literature focus on a lot, is on mortality estimates. So this literature, which is mostly used by environmental economists and not very much by health economists, is focusing on mortality. So there are very few estimates on morbidity that we could use out there in order to evaluate policies. So this second convention that we were talking about is this quality. So the quality literature is actually pretty good at focusing on the evaluations of mortality, of morbidity. So, and because basically the problem that we're facing in health economics mostly relate to morbidity estimates. So if you take cost-effectiveness analysis, which is the tool that exploits this health benefits, what you are doing with that is maximizing the level of health that you're providing to the population. So basically, you're choosing the policies that are going to maximize the level of health. Of course, if we're focusing only on the health aspect on a particular policy, then cost-effectiveness analysis is a pretty good thing to do. But the second argument in favor of using cost-effectiveness analysis is basically that it's accepted along the health economic, the persons dealing with health. So basically that's a good defense. But the problem is that, sorry. So what I wanted to say with the cost-effectiveness analysis is one of the problems with cost-effectiveness is that you're not able to satisfy this Calder-Hicks criteria. So it's pretty hard to transfer health from one person to another person. Rather, you can transfer money from one person to another person. But what it would be ideal to do is try to find a way to merge those two literatures. So the cost-effectiveness analysis has an abundant literature on morbidity effects that could be used to fill the gap in the cost-benefit analysis literature. So what would be nice to do is to try to find this link. And one way to do that is to monetize these qualities. So basically, it has been done before. So the Federal Drug Administration has done so for the last 10 years. And for 2003, for example, there was this policy trying to see whether it should be beneficial to mandate the food producers to put on their labels whether to disclose the information whether they had trans fats or not. In a quality measure on a monetary quality that the Federal Drug Administration used were of 100,000 euros. So, of course, there are many limits to this. Should we be using only one quality, only one monetized quality number? So is 100,000 euros a pretty good thing to implement? And of course, the questions that we would have to ask with this quality measure is of who should we elucidate the values from? Should we elucidate the values to doctors or from the patient? So if you argue, okay, let's elucidate the value from the patients, then it will be a pretty good thing to do because those are the ones who are suffering from the disease. But of course, you might think that there might be a potential strategic bias. So the strategic bias meaning maybe what I'm going to say is going to influence what policy decision makers are going to do, and hence I will try to bias downward or make appear the disease be as bad as that much. I'm not saying that's a good argument, but the possibility is out there. But if we use the doctor's preferences, then we lose position. Or should we use the preferences for the general population In any case, for example, here in France, we are the ones who are financing most of the diseases from the patients. So I leave the panel. I think that's it.
Very good.
Thank you.